Thank you for the kind invitation to talk, and welcome to everyone who's come here today. As I look around the room, I don't see many familiar faces, so I'm expecting that you've all come from places far away. So welcome to the Royal Free Hospital, which is where I work, along with Dr. Thorburn, who's one of my colleagues here. So this is a very broad title, and really, I think there's no one size fits all. Many people with PSC are seen in smaller hospitals, where they may be seen by somebody who's a gastroenterologist with an interest in hepatology. At the Royal Free Hospital, the hepatologists only see hepatology patients, so we are very specialist and focusing in on these rarer liver diseases. So there are different types of services depending on where people are seen, but broadly speaking, I'm just going to talk a little bit about what the condition is and what sort of things we are doing as we see people in the clinic. So I've just written a list of things I think that we should be doing for our patients. So it's very important to know that we've got the right diagnosis, and I'll talk a little bit about that because sometimes there are extra conditions that can go along with PSC that need their own special treatment, or sometimes it may be something different entirely. What's very important is to understand where somebody is in the disease journey, whether this is very early and mild disease, or identifying those patients who've got more advanced disease where they're more likely to be issues that we need to deal with. I think one of the big issues for PSC is that there's a lot of uncertainty about what the future might look like, so giving people really good advice about what they could expect and answering their questions is an important part of the consultation. Thinking about general measures that everyone can take to improve their health. Symptoms are often a big issue for people, particularly symptoms like tiredness and itching, and giving you the best advice about that. And we do offer some check-up tests, so things that we do routinely to look out for issues that can arise, and I'll talk a bit more about that. And I think what's important as well is to be available for patients. Often we're seeing people maybe once a year or once every 6 months, but we need to have a way of patients contacting us when they have a concern rapidly so that they can get access to the right advice. And we mentioned research already. It's part of the NHS constitution that patients should have the right to participate in research. And over the last few years, there's been a lot of opportunities, which is great, but we're really keen to incorporate that into everyday practice in the clinic. So first of all, getting on to what the correct diagnosis is. So just a bit of a definition. What do we mean by PSC? So it's a long-term chronic liver disease. What it's characterised by is when there's inflammation in the bile ducts, and that can lead to scarring. Those scars can make the bile ducts narrow, and I've got some pictures just to illustrate what I mean by that and what can happen. Eventually...
Disconnected.
Am I still recording all right, or should I press something? Okay, I'll carry on. So these narrowings in the bile ducts can lead to scarring in the liver tissue itself, and that's when the scarring gets very advanced, that's what we call cirrhosis. PSC is what we consider a rare disease, and when we think about how common a disease is, there's two factors that we think about. How many people every year are newly diagnosed with the condition, or how many people actually have the condition. And the first one is incidence, so how many people every year. There are studies that look at different populations in different countries, and sometimes the estimates can vary. So it may be as few as less than 1 every per 100,000 people, or as much as 1.5. So that would be around about somewhere between 300 and 900 people every year having a new diagnosis of PSC. And because it's a long-term condition, there's a lot more people living with it. So we think, based on estimates in countries like the UK, that there might be somewhere between 4,000 and 10,000. Now, Martin, you can tell me how many members you have and whether you think you've got all of these people as your members, but hopefully more people, most people will join the patient group. So going back to just what is PSC and how we diagnose it and what it means. So there's a couple of pictures here. This one is just a drawing of what the liver looks like. It sits up on the right side under the tummy, and it's this sort of shape. So this is the right side here, and this is sort of the middle of the body here. And underneath the liver is the gallbladder, and this is where the bile that's produced by the liver drains through all these tiny little tubes that eventually join together into larger tubes and then drain down into the small bowel, which is down here. And if we look at the liver under a microscope, we can see these tiny little tubes draining the bile into the small ones, which then join like the branches of a tree into the bigger ones. So in the normal liver, sorry, I thought I had another picture there. So in the normal liver, this looks very smooth, but then when we do scans to look for PSC, one of the things that we're looking out for is seeing lots of different areas of narrowing with all these different branches within the liver. So what else might it be if it's not PSC? Well, there are other liver diseases that are very common, and very often this might be picked up by somebody having their blood test done, and the blood tests look abnormal, and we're asked to try and find out what it is. Other liver diseases that are very common in the general population can also affect people who might have PSC, and this is some fattiness in the liver or reactions to any sort of medication, so we always think about that. There's a condition that some people may have heard of, which is a special kind of cholangitis, but it's caused by a particular sort of immune activation of cells which produce this protein IgG4. Now, the importance of this is that if somebody's got IgG4 cholangitis, then there's different treatment and they may respond to steroids. Some people with PSC, especially the younger age group, as well as the bile ducts being inflamed, these liver cells here that sit in between the bile ducts can also become inflamed. And this is called an autoimmune hepatitis overlap. And again, this can respond to steroids as well. So the diagnosis, there's no one particular test which can say it definitely is or definitely isn't, but it's mostly a combination of the typical picture and the typical pattern that we're looking for. So somebody might have no symptoms at all, or they might have the symptoms I've described of itching and tiredness. The blood test, which I'll talk about the typical pattern. Liver scans, which are often ultrasound or MRI scans. The liver biopsy, where we take a sample of the liver tissue, is only needed under certain circumstances. If we've got a liver scan that shows the typical features of PSC, then we're happy that we don't need a biopsy usually. But there are some circumstances where it can be helpful. In the liver function tests, what we're looking out for is a high alkaline phosphatase, which is an enzyme that's produced in the bile ducts. So any problem with the drainage of the bile ducts, it will go up. Most people are not jaundiced. Jaundice is when the bilirubin increases. If it is up, then that tells us that things are more severe than mild PSC. The other liver enzymes here are produced by the liver cells. So these are usually normal. Sometimes they may be a little bit high. If they go very high, that's when we start thinking of other causes. So here's my picture of the bile duct. So this is what an MRI scan of the bile ducts look like. We don't see the liver here because what the scanner is doing is detecting fluid, and the bile is fluid. But if you remember the picture I had before, this is the gallbladder here sitting under the liver, and this is the main bile duct draining into the intestine. And these patches here are just patches of fluid in the intestine. So this is what normal looks like. And because the bile duct is very thin, it's usually very smooth and small. And when someone's got PSC, we usually see this sort of picture. This is quite severe. It may be milder than that. But we're not seeing the nice smooth branches of a tree here. We're seeing bits where the bile ducts are bigger than they should be, and then we're seeing bits where they don't seem to join up. And this is where the narrowings are, and then the bile ducts get bigger as the fluid can't flow through. So if we get a scan like this in somebody with the typical symptoms, then we could be happy that that's what it is, it's PSC. I mentioned that sometimes we do a liver biopsy, and this might be because we suspect somebody's got PSC, but their MRI scan is normal. That occasionally happens, and so we might need a biopsy to help us. Now, this is a normal liver under the microscope. What we're looking at here is the bit where the bile ducts and the blood vessels join together, and these bits here are where the liver cells are. And so this is what we normally see is these structures here, which are tubes cut across, so they look like a circle, and these cells are all nice and healthy looking. On the other side, we can compare. This is the same sort of area here and here. So you can see it doesn't look right at all. But what we see is this layering of scars, which is what's called an onion skin, like the layers of an onion skin, around where the bile duct should be. Instead of seeing all these liver cells, we see these little inflammatory cells. which are causing inflammation around the bile duct. And instead of seeing these nice, smooth cells here, the cells in the bile duct look all irregular and they don't look particularly healthy. So that's what it might look like under the microscope. So with all that in mind, what is the sort of person where we're thinking about PSC as being a problem? Well, it can be diagnosed in anyone, from any age, but it's often people in the younger age group, in their 30s and 40s. There's a very close association with colitis, as I'm sure you will all know. It's around about 80% of people already have colitis when they find out they've got PSC. And because it's a disease of the immune system, then somebody might have another immune disease or perhaps a family history of other immune diseases. So moving on to some of the advice that we give, there is some general advice that's applicable to everybody with any kind of condition, but particularly if you've got a liver condition. And it's really important to try and keep a healthy weight so that you avoid extra things like fatty liver occurring on top of it, and keeping yourself physically fit and active. We often get asked about whether somebody can drink alcohol if they've got a liver disease. Now, of course, PSC is not at all caused by alcohol, but it is important to remember that the recommended limits are for people that don't have liver conditions. And if your liver is already being injured by one thing, then trying to avoid something else that could harm it is also very important. Sometimes people are not sure what medicines they can take, because any medicine in a small number of people can cause a reaction in the liver. And so it's important when you're being prescribed something is to ensure that whoever's prescribing it to you knows that you have a liver condition and to make sure it's safe for you to take. One of the things that we commonly come across as causing injuries to the liver are not actually prescription medicines, but what are often perceived as being safe and harmless as being herbal remedies. But these are chemicals too, and quite a lot of them can cause liver reactions. So it's really important to check if you're thinking of taking some herbal remedies or natural remedies. So thinking about what might happen once we've got the diagnosis. So what this slide is just showing here is a little bit about what symptoms can be like, what the activity of the colitis can be like, and what can happen to the stage of the disease. So I was saying some people with early PSC don't have any liver scarring, and then things, as time goes by, there can be more scarring leading to the end stage of cirrhosis. And what we're talking about here is often many, many years. And this is not inevitable. Some people will keep very mild disease for decades. Often as time goes by, the liver symptoms will go up and down, the blood tests will go up and down, and sometimes they get so severe that some people need a transplant, as many of you will know. And occasionally, in a small number of people, that condition can come back after the transplant as well. So this is one of the things that feeds into the uncertainty, because we don't really have a good way of predicting what's going to happen. There is some research going into how we can do that better with some promising results, but at the moment it still is quite an uncertain prospect. Martine talked a little bit about a lot of people being seen in smaller hospitals or bigger hospitals. And as I mentioned, the progression to worse liver disease is not inevitable. Older studies really focused on the larger hospitals, and in the larger hospitals generally there's more people with more severe, the more severe end of the spectrum. So we used to have an idea that things are probably worse than actually they are. And when bigger studies are done looking at whole populations, the risk of these serious events happening, like the liver getting worse, jaundice, cirrhosis, actually seem to be much less common. So what this is showing you is a study that was published a few years ago from the Netherlands, and their study was this population-based group of people with PSC here. The Netherlands has very good registries where everybody with a condition is registered, and then you can follow up what happens to those people. And over the course of 25 years, 30 years, this is the number of people who got a really serious complication of their PSC or needed a transplant. So if you look at 10 years, we're looking at around about 15%. Now, we used to think that in the people who were in the bigger centres, we used to think that was much more likely. So if you have a population who followed up in a transplant centre with a more severe disease, and at 10 years, maybe up to 40% of them would have needed to transplant. So there's a real shift towards recognising that there's a lot more mild PSC in the population. And I think that's an important thing to tell people about as they come to you with early disease, that perhaps what was thought to be a really severe progressive condition might not happen. Okay. So just moving on to talk a little bit about symptoms and some of the advice that we give. So symptoms for PSC don't go along with how bad the scarring is in the liver, and they can happen at any time. I've mentioned itching and fatigue. Jaundice can be due to worsening scarring or a problem in the bile duct. Abdominal pain is very common, and sometimes this goes along with an infection. And obviously when the fever comes, we might need antibiotics. And I think still a symptom, and going back to the uncertainty issue, but I think that still is something that troubles people and affects their quality of life. When things get a bit worse, then we're thinking about the more serious side of things. And what we're looking at here is what happens when the liver gets scarred. So when the liver gets scarred, you can form varicose veins internally. So when somebody's got that more advanced disease, then we talk about doing extra tests. This picture here is of looking down someone's esophagus or gullet, and these are the varicose veins on the side. This doesn't project quite so well as it does on my screen, but they're little long tortuous channels which are just larger veins inside. The scarring can lead to fluid retention, which we can treat with various measures, and sometimes people will suffer with poor concentration, loss of appetite, and loss of weight. So all of these things are things that we can give some advice about dealing with. Itching is one of the big topics. So sometimes people will have itching so severe that they want to take some medication for it. So there's simple things like antihistamines can help. The first thing that we try is this drug called cholestyramine, which helps to remove the bile salts from the body and can help in many people. It's quite difficult to take, so it's a powder and it's can cause a bit of nausea, stomach upset. So some people say, well, actually, I'll cope with the itching. If they're still having a lot of symptoms, then these other drugs that are mentioned here are often very helpful. But if there are other issues that can't arise with those treatments, or the itching is still very severe, then we have extreme measures. But of course, the simple things have less side effects, the more complicated things have more side effects, so each step we take we have to discuss that carefully about whether it's the right thing. Tiredness is a very common thing that patients tell us about. It doesn't affect everybody by any means, but it can be a very difficult thing to treat, and often there are various different factors that help it. So if somebody's not sleeping because they're itching, then treating the itch can help the tiredness. Sometimes there may be low mood or anemia or deficiencies in vitamins, and we can check for these things and try to treat them. Many people find that they just need to do some lifestyle changes to help with the fatigue, so that they're moderating their levels of activity appropriately, and sometimes even a sort of gentle exercise program can help with that fatigue. Okay, I'm just going to talk a little bit about jaundice. I mentioned that sometimes we have narrowings in the bile duct, so a lot of people with PSC don't ever develop one of these problems, but sometimes the main trunk of the bile duct can become narrowed, which leads to blockage, which can lead to jaundice, and this can often prompt an infection. When we find something like this, we might want to do a procedure to open it up. Now, there's been some recent research looking at what the best way is to do with that, which the possibilities are that we could use a balloon to open this area, or to leave a tube in to help it drain. That's called a stent. And there was a recent study which showed that the balloon and the stent were similarly effective, but with the stents there was a little bit of extra risk of some of the side effects of the procedure, which would be infection, inflammation in the pancreas. So in general, we prefer to use the balloon dilatation now, if we can. Okay. I mentioned checkup tests, and this is something that we're often doing and quite keen on, because a lot of the time if you find a problem early on through a checkup test, then it's easier to treat and more effective. So when we see people, we will talk about symptoms, we'll look at the blood tests. I mentioned how bad the scarring is in the liver. There's no real perfect way of telling how much scarring there is in the liver, but we have a guide. One of the tests that we use is a little bit like an ultrasound. It measures the stiffness of the liver, and when the liver is scarred, that stiffness value becomes higher. So we often do that, offer our patients that test once a year so that we can see how that number is. We'll do a scan to look at the liver once a year. And if somebody calls us and they've got symptoms, or they come to the clinic and their blood tests are worse, then that would prompt us to look and see if one of these issues has developed that I mentioned. If somebody's reached the end stage of scarring in the liver, then we would look for those varices that I mentioned, and we'd increase the frequency of the ultrasound scanning more often, every 6 months instead of a year. I mentioned vitamin deficiencies as being quite common. We offer to do bone density tests because vitamin D can lead to thinning of the bones, and this is common in people with all sorts of liver diseases, but particularly conditions like PSC. So we'll look at the bone density when somebody's diagnosed, and then if it's normal, we'd do it less frequently. If it's low, we'd check it again sooner, and we make sure that the vitamin D level in the blood is adequate. Okay. Now, in our clinic, we are hepatologists and we just deal with the hepatology problems. So our patients who have colitis will also see a gastroenterologist, which might be somebody here at the same hospital or somewhere else. Many patients will see the same person for their colitis and for their PSC if they're being seen by a gastroenterologist with interest. But we do make sure that people that know that they should be having a colonoscopy once a year when you have a diagnosis of PSC and colitis. And so for those patients who don't have a diagnosis of colitis, we would recommend that they have a colonoscopy at their diagnosis and then 5 years onwards. So that was a lot of information, I'm sure, which I've gone through, but I'm very happy to take any questions, and I hope that's been helpful. Thank you.